Dr. Pramod.
Thank you, Dr. Ravivan, for introduction. So, anyone who are in outside, please come in. We are going to start for the next session. So the next session is what's new in spinal cord stimulation, and we have a very guest speaker, Professor Billy Herr. He is a professor and medical director of Department of Pain Medicine, the University of Texas, MD Anderson, Houston, from USA. He also has a number of publications in my hand, more than 10 pages, so we can't read it all. So I think everyone would like to listen to his presentation. So please join me together to welcome Professor Billy Herr.
Okay. Thank you very much for the introduction. This is my first time in Thailand, and it's 1 o'clock here, but it's midnight in Houston. So if I fade away, and I had a full stomach too, so please understand. So my topic is an update in neuromodulation. I have no relationship with any companies, so whatever I say has no conflict. So what I want to talk about today is we're going to go over some problems with the all spinal cord stimulator system, especially the tonic system. Okay, in last 5 years, a lot of new technologies has risen. Okay, so many companies now coming up with new technologies. Of those, I will talk about mostly on burst stimulation and the dorsal root ganglion and high frequency stimulation. And I will try to review some mechanism that has been proposed, and then learn to apply these new technology and specifically how to make a good patient selection. Remember, stimulator is not for everybody. It is usually reserved for the last resort refractory pain patients. Okay? And especially for the dorsal root ganglion, I'll show you how it's different from traditional stimulator technique-wise. So as you heard the lecture this morning, neuromodulation has been around for 50 years. Okay? It's a fairly effective agent in treating various refractory pain condition and has a minimum side effect, and fairly safe, reversible. Unlike a spinal surgery, this is totally reversible. Okay? And in the long run, it's cost effective, as we talked this morning. So traditional tonic stimulation, the spinal cord, and interfere with the transmission of pain to the brain. Okay? So basically, you wanna convert this red, hot, painful area into soothing, cool paresthesia. That's what it is. That's a simple concept. Okay? However, this cool, soothing paresthesia, which is also tingling sensation, a lot of patients don't like it. Okay? Now the pain is gone, but this persistent tingling sensation at nighttime, a lot of people have a difficult time sleeping. Okay? They rather have no paresthesia. Okay? And especially with the positional changing. Remember, this is placed in the epidural space. Now, if you change your position, especially lying supine, spinal cord gets closer to the stimulator, electrode, because of gravity. Now they get shocked. Okay, so a lot of patients complain of a different stimulation with the positional changes. Okay. And the indication, as you saw earlier, has some limited indication. Okay. Many failback surgery or symptoms, failback symptoms with a radicular pain. Okay. and a lot of spinal diseases that has a radicular component, such as epidural fibrosis, arachnoiditis, and complex fusional pain syndrome. So far, traditional tonic stimulation has very narrow indications. Okay, in the United States, insurance approval is very limited to certain diagnoses, okay, such as very bad complex fusional pain and radicular pain. Okay. And it's very difficult time covering the certain area, such as just the back pain, groin pain, knee pain, feet pain, toe pain, okay, and chest wall pain. It's a very difficult area to cover with traditional spinal cord stimulations. And so far, with the traditional system, we have some fairly high complication rates, okay, especially lead migration, okay, and battery problem. Okay. Now, lead migration in the last 10 years has improved dramatically because every company, they came out with a better anchoring system. Okay. And the battery, most of us have been using last 10 years a rechargeable system, okay, and that has been problematic. Okay. And even if the system is working really well and no complications, you lose efficacy with time. After 2 years, a lot of people complain that the stimulation is no longer giving the same relief as at the beginning. Okay? There's a very short honeymoon period. So this is a publication published a little more than a year ago. This is the largest international outcome study on spinal cord stimulation. Okay? They're looking at the long-term outcome on about 1,000 patients. Okay? This is basically Europe and United States. So put it simply, what they found was that there's an inadequate pain relief was the primary reason for removing the system. Okay? And the higher removal rate was observed for the rechargeable batteries. So there's a clear need for other options that are superior than tonic stimulation and the rechargeable free system. Okay? So when you look at this diagram, conventional non-rechargeable battery, this is a conventional rechargeable series. That's twice as much removal rate. Okay? Even for the newer high-frequency rechargeable system, that is higher than the conventional non-rechargeable batteries. As you heard on the news, when you try to fly airplane, they make sure they don't put the rechargeable batteries in your check-in baggages. Why? Catches fire. Okay? You saw earlier, a number of years ago, they wouldn't let you fly with the Samsung Note 9, whatever, and they wouldn't let you put the laptop batteries check into your baggage because it can catch fire. So we have a lot of problem with the rechargeable battery technology, even nowadays. So what's new nowadays? So last 5 years, I mentioned there's a lot of explosion of new technologies. Okay? Instead of tonic, now there's a burst stimulation, okay? High frequency stimulation, up to 10,000 frequency. Okay? Normally, tonic stimulation is between 50 to 150 hertz. Now this is 10,000 hertz. Totally new technology. And also there's a dorsal root ganglion stimulation produced by 2 different companies. Okay? This way, we can target the specific area that is painful, not stimulate the area that does not need to be stimulated. There's a very small wireless stimulation system now, a stim wave. And also, remember, our stimulators used to migrate a lot with movement. Now they have stretchable stimulator. Okay? They stretches with your movement, okay, and they're very durable. And nowadays, most of them are MRI compatible. Okay? Especially in my institution, which all our patients are cancer patients, MRI is very important. Okay? And we cannot remove a stimulator just because they need MRI. And nowadays, system is very efficient. They use a lot less power. Okay? So therefore, there is a resurgence of non-rechargeable batteries, okay? Because we want to just get away with the rechargeable batteries altogether. Okay? And because of new system is able to cover more different type of pain, there's emerging newer indications for spinal cord stimulations. So my personal experience, okay, from 98 to 2013 at Duke University, I was putting more than 100 implants a year, mainly because Duke has 13 spine surgeons. So they provided me the non-stop Fairback surgeries. Okay? Now I come to MD Anderson, there's no such Fairback surgery patients. They're all cancer patients. Okay? And requires what? MRI every 6 months. Okay? Back then, we didn't have MRI compatibility, except Medtronic just introduced MRI compatibility system. But then I didn't have any patients that really need stimulation. Okay? But as the technology improved, starting about 2017, now I was able to find better patients that can be helped by the new technology system, which I will talk about it. Okay? So last year, I put in 36 implants. Okay? Now I'm catching up. So look at our MD Anderson cancer patients. Okay? Most are cancer-related pain, chemo-induced peripheral neuropathy, okay? Which is a big dilemma. Okay? We don't have a solution for this. Okay? Some of them are suffering, after they suffer through the cancer, now they have to suffer with the chronic persistent pain. We have many, many post-mastectomy syndrome patients. Okay? Pain in the chest wall, upper extremity because of edema. Okay? And most of them are immune suppressed. So there are also a lot of patients with the post-herpetic neuralgia, okay? Which is in itself very difficult to manage. Okay? And also we have a lot of areas that are difficult to cover with spinal cord stimulation. Okay? Very few traditional Fairback or complex regional pain syndrome. Okay? All our patients have a cancer. Okay? So it's very difficult to find traditional chronic pain patients. And MRI compatibility is a necessity. And we cannot put any MRI non-compatible system on our cancer patients. Okay? Fortunately, since 2013, the new technology, new hardware, software, and most of them are MRI compatible. And we never had to remove the system because they need MRI. So let me talk about my personal encounter with the new technology. Remember when I first moved to MD Anderson, I just forgot about stimulator. Okay? And all of a sudden, I ran into this 77-year-old female with history of polycythemia vera, myelofibrosis, and who had chemotherapy. But her problem was non-cancer related. She had a chronic shoulder, back, and thoracic back pain. Okay? And the neurosurgeon has placed a pedal lead in the cervical and lower thoracic area 20 years ago. Okay? And 10 years later, same surgeon took the battery out because it was heating up. The patient complained of an area the battery site was too hot. So he just went in and took it out. Since taking out the stimulator, the patient was using more opioid. Okay? And she was getting constipated, and she approached me and said, I want to reactivate my old spinal cord stimulator, okay, because I don't want to take opioid. So when we looked at her, she had a cervical pedal lead here, and she had a low thoracic pedal lead. The problem with this is, when you look at this low thoracic lead, surgeon not only removed the battery, he cut the wire. Okay? So this is useless now. Cervical lead, fortunately, had extension. Because battery was far away, he put an extension, he cut the extension. So this cervical lead is salvageable. Okay? So what we did was we opened up the connecting side, removed extension, and put the battery. To my surprise, I didn't know what this battery was. It had to be a burst battery. You can do the burst stimulation, not traditional tonic stimulation. Okay? Just with the C-spine lead, we were able to cover all her pain. Okay? Shoulder, thoracic, and back pain. And patient was, again, not using any opioid. Okay? And we were able to, and this burst battery is non-rechargeable. Okay? And patient like this because no paresthesia. Patient feels absolutely no paresthesia. She can sleep better, okay, and uses very low energy. So another case was a post-mastectomy syndrome with a lymph edema. 65-year-old female with metastatic breast cancer, set up a radical mastectomy. Okay? She has chronic lymph edema because axillary dissection caused a problem with the flow of blood. So it now left arm is swollen all the time and pain. Okay? So did a cervical spinal cord stimulator trial with the burst mode. She got greater than 50% pain relief. She improved function of her arm. And she also said, my edema is better. Why? Sympathetic block. Okay, you saw the earlier slide talk this morning, the wound healing occurs because perfusion improves with stimulation. Sympathetic block. So her edema improved because of improved circulation. Okay? She discontinued using opioid. Okay? Overall, she was very happy, and we proceeded with a permanent implant. So this is her cervical lead. We inner the T2, 3 inner space and put it on the left side. Okay? And then we anchored her here. She's happy. So what is burst stimulation? Okay? Burst stimulation is discovered by Professor Dirk de Ridder in New Zealand. Okay? It is a more natural stimulation paradigm. Okay? Body recognizes it as more natural. It's so natural, you don't feel it. Okay? When it's a tonic, it's not natural. You feel it, paresthesia. Okay? And this technology has been used not only for spinal cord stimulation, it has been used for cortical stimulation to get rid of ringing in the ear, phantom pain, and addiction. Okay? So when you compare the tonic, our traditional tonic versus burst stimulation, tonic stimulation, you have a periodic large stimulation. Okay? So large you feel it. Okay? But on burst stimulation, you have a packet of very small, 5 burst stimulation occurring same time, okay? Very fast, and it happens periodically. So this is so small that you don't feel anything. Okay? So you can look at it as a one large, strong guy versus small 5 little guys. Who's stronger? 5 little guys. Okay? And it is a burst is naturally occurring and interpret differently as compared to the tonic stimulation by our nerve system. Okay? Our thalamus, which relays a signal from spinal cord and relays to the brain, can fire either tonic or burst mode. Okay? And burst mode is much more potent activator of our cortex. Okay? And this burst neurons are not influenced by the tonic stimulation. So when you look at here, here's the thalamus that relays signal from the spinal cord to the cortex. Okay? The tonic stimulation is very linear. There is a one tonic stimulation relayed, cortex responds with the one response. Okay? So you can see the one response, one cortex responded. On the other hand, when there's a burst stimulation related to the cortex, there's a much bigger response in the cortex. Okay? So one tonic, one small response. One burst, big response. So you can see it's much more robust activator of cortex. And reason is it is a stronger response is because of a tonic firing that it is the temporal summation of these small ones. Okay, 5 packets causes temporal summation, therefore response is bigger. So if you look at the detail here, you can see here we have a 5 little burst, okay, and then 40, it's a frequency of burst is 40 hertz. That means it happens 40 times per second, okay? And the duration is 25 milliseconds, where 9 milliseconds is the burst and 16 milliseconds of quiescent period. So this is an animal study where they look at the spinal cord stimulation relaying to the midbrain and to thalamus. So in the midbrain, we have a neuron called gracilis neuron. Okay? So they look at the wide dynamic range neurons as well as low threshold tactile neurons. Now, if there's a tonic stimulation coming in, guess what? These neurons respond. Okay? So is a low threshold. If there's a tonic stimulation, there's a big response. On the other hand, burst, there's no response. So this is another confirmation why patient feels paresthesia with the tonic stimulation, but they don't feel anything with the burst stimulation. Okay? And also, mechanism of stimulation is very different. It goes through the different pathway. Okay? So this is another animal study, rat model with the cervical radiculopathy. They placed the stimulator at the C3, C4 with the and what they did was they stimulate the rats and then turn on the stimulator. Okay? Now, tonic stimulation. Remember earlier this morning, one of the mechanisms was the release of GABA, okay, inhibitory neurotransmitter. Here, yes, tonic, GABA is released. When you put the GABA antagonist, look at this, GABA is inhibited, okay? But on the other hand, with the burst stimulation, you add GABA antagonist, there's no changes. Clearly showing that the mechanism of stimulation is very different from tonic stimulation. So this is a nerve root compression model. Okay? When nerve root is injured, body produces GABA to counteract it. Okay? So here, when nerve is compressed, GABA is increased. Okay? When you add tonic stimulation, GABA gets released. Burst stimulation, no GABA. Okay? So burst stimulation is GABAergic independent, okay, not related. So similarly, they look at the clinically, when you look at the actual back pain, okay, there's a baseline, you turn on the tonic stimulation, pain is reduced. When you turn on the burst stimulation, pain is even further reduced, okay, indicating it's much more effective. Same for the limb pain, okay. And when you look at sensory and affective component through the McGear questionnaire, again, it is much more effective than tonic stimulation. Okay. So this is the pain for diabetic neuropathy, very similar pattern. Okay. Tonic stimulation reduces pain, but burst stimulation reduces even more. Statistically significant changes. Okay. Failed back surgery, same. And those poor responders, failed backs, even those patients get meaningful reduction with the burst stimulation. So this is actually a prospective study, called Sunburst by Team Deere. Okay, so they look at the prospective randomized control trial using, they compare the tonic versus burst. Okay. So what they did, they wanted to just demonstrate not only safety but efficacy. And so inclusion criteria, they look at the patients who went through the successful trial with the tonic stimulation, at least 50% reduction in pain. Okay? Chronic intractable pain of trunk as well all limb. Okay? And their average pain score over 7 days has to be greater than 60 millimeter out of 100, okay, prior to implant. And they're taking pain medication very stably, not changing the doses all the time. Okay? And the exclusion criteria was patients with a major depression, okay, or history of substance abuse. So they randomized 170 patients, and they enrolled 170 and randomized 100 to two different groups, okay, tonic and burst. Patient demographics, average age about 59. They had an average duration of pain is about 13 years, and 60% was female, about 42% fell back, and about 37% with the radiculopathy. Okay. So if you look at the intent to treat analysis, they're not just non-inferior. Okay? They're actually superior in overall pain score, pain in the trunk, pain in the limb. Okay? And 70%, vast majority of patients preferred not having any paresthesia, although about 19% did prefer paresthesia. So burst stimulation activates neuron that cannot be influenced by tonic, so it's totally separate pathway. Okay? And burst has a greater impact on the cortex response, largely paresthesia free, and power requirement is usually lower, so you don't have to use rechargeable batteries. Okay? These batteries comes with the average of a 5 to 7 year warranty. And based on the Sunburst study, they got level 1 evidence of a superiority over tonic stimulation. How about dorsal root ganglion stimulation? We know that dorsal root ganglion plays a key role in neuropathic pain. Okay? A lot of ongoing basic science studies, and more the data is coming out, and the importance of DRG. Okay? And it is, for that reason, is a particularly useful target in treating the focal pain. Okay? And unlike a spinal cord stimulation, DRG stimulation is totally position free. Okay? They can move all they want, DRG never moves. okay? And electrode on the DRG is never positional, okay? And therefore lead migration is minimal. So this is another team there study on DRG, okay? They look at the complex regional pain syndrome after 1 year in a randomized fashion. They enrolled 150 patients, and anyone who goes to, or everybody goes to the Medtronic tonic stimulation trial. 50% reduction in pain, they get enrolled. Okay? It's even enrolled between the two, DRG and tonic, and follow for 1 year. Okay? And they are mostly chronic intractable pain of CRPS or peripheral coralgia. So they look at the patients who responded with greater than 80% pain relief. Okay? And 70% of them were DRG patients, and about half of them tonic stimulation. Okay? And they were looking at the paresthesia intensity. Okay? So paresthesia intensity is very small on DRG group, and they are not positionally dependent. Whether it's upright or supine, no changes. Okay? So look at how intensity is around 2. On the other hand, tonic control group, their intensity is much higher. Okay? So they feel it. Okay? Also, they are positional. Supine, you get a lot more stimulation versus sitting upright. And also, therapy is much more specific with DRG. Okay? 95% of DRG patients getting stimulation where it hurts. Okay? Or control, only 60%. So they're getting, 40% of people are getting area that does not need to be stimulated. Okay, summary, DRG was superior at 3 and 12 months compared to control group. Okay? And it improved quality of life, psychological disposition, activity level, less paresthesia, and more specific targeted paresthesia. Okay. How about chemo-induced neuropathic pain? Okay. Chemo-induced peripheral neuropathy is a big problem for cancer patients. Okay. It's one of the most abundant patient population in our institution. Okay. It can cause severe pain, okay, even after the chemotherapy is over. Okay. Impacts their activity of daily life, walking, riding, even putting a shirt on, okay, picking up the coin on the floor. They can't do it. Okay. It can cause even more serious problem. Okay. It can cause heart rate changes, blood pressure changes. They can fall. Okay. Sometimes they have trouble breathing. They get paralyzed, organ failure, because every nerves that innervate these organs are impacted by chemo. Okay. And after now, there's no effective treatment. Okay. So this is an 82-year-old male with history of colon cancer, prostate cancer. Okay, studies supposed to be resection, chemotherapy, radiotherapy. Okay. Now he underwent chemotherapy in 2010 with these chemo agents, and they're beginning to develop a progressively worsening chemo-induced neuropathy. Okay. And he's developing numbness, tingling, throbbing pain, both hand and feet. Okay, worse in the hand and worse at night. So he cannot sleep because of pain. And the average pain score is about 8 out of 10. Okay. Past medical history, hypertension, well controlled, hyperlipidemia. He had a colectomy in the past, social family history, he doesn't smoke, he's a retired small businessman, okay? No alcohol, no tobacco, never had exposure to any chemicals. But he has reduced the sensation to touch in stocking glove fashion in all extremities. Okay? Muscle strength is intact, no allodynia, he can walk okay without any problem. He takes aspirin, beta blocker, and cholesterol medication. And he's on pregabalin, 100 milligrams 3 times a day. Okay? And he has failed the gabapentin in the past. Okay? So our initial plan was diagnosis, chemo-induced neuropathy. We increased the gabapentin, we doubled the dose. Okay? And we started on tramadol, okay, and discussed the possible implant if all these measures fail. Okay? Symptoms did not improve. His pain scores remained around 7 to 8 out of 10, and we also again discussed the possible intervention in the future. So spinal cord stimulator trial started in 2011. This was tonic stimulation. We couldn't get it. The trial failed. Intrathecal zirconatide in titrating dose 3 times in a row, no response. Okay. Intrathecal opioid and local anesthetics, no response. Okay. Now Boston came out with the 16 content. So this actually was done by one of my colleagues. Okay. And more lead did not lead to more relief. Okay. EMG study did show sensory polyneuropathy. Okay. Bilateral lumbar sympathetic block, no response. Okay. Schnabel therapy, 10 sessions in a row, no durable response. Okay. So we rotate to different tricyclic antidepressant, duloxetine was tried, opioid, different opioid, transdermal medications. Symptoms got worse, 9 out of 10. And we discussed possible DRG. This was in 2015 because FDA hasn't approved yet. So we told them, well, as soon as the FDA approved, we should try this. So patient wanted to be on the waiting list, #1. So finally, time came, December 2017. We placed the bilateral L5 S1 stimulator lead. Like you can see here, there's L5 and S1. Okay. Since then, this patient has been traveling around the world. Okay. He said his average pain score is 3 out of 10. He's able to sleep well, travel without any much of pain, off all medications. Okay. So this is my fellow. While I'm in Thailand, she's in Las Vegas presenting this case. Okay. This is how our fellows get training without any pain. They're enjoying life. So DRG is sub-threshold. Again, they don't feel any paresthesia. Okay? Paresthesia-free frequency is about 50 hertz, which is similar to tonic stimulation. And amplitude is less than 1 milliamp. Okay? Typically between 0.1 to 0.5 milliamp and pulse width of 200 microseconds. We don't exactly know what the mechanism is, but it's hypothesized that it inhibits neuronal activity through the activation of a beta fiber, just like what Melzack and Wall has proposed. Okay. So this is the DRG, another DRG, 43-year-old female with no history of cancer, but chronic abdominal pain, pelvic pain due to the neuropathic pain and from the pelvic congestive pain syndrome. She also had a genital pain along with the rectal pain from the endometriosis. Okay. So this patient, we placed the T12, L1, and the S2 DRG lead. During the trial, she got 75% relief. Okay. And so this one, I just want to briefly go over how the DRG is placed. It's a little bit different technique. Okay. So we are targeting left T12 DRG. You go to contralateral L1. Okay. And aiming for, look for the epidural space. Okay? So this is 2E. Once we find the epidural space, electrode is put in. Now this electrode is very, very thin. Okay? So it has to be inside the sheath. So we push the electrode and sheath together. Otherwise, it's going to bend all over the place. Okay? So we play. This is inside the sheath. We're advancing it in epidural space. Now, it has natural curvature. So we have to bend it, rotate towards the left side, so it will go to left side. Okay, so now it's going to left side, keep going, and then finally into the foramen. Okay, T12 foramen. Okay, so we keep advancing because we want to create a loop. So when we create a loop upwards, it's going to come back in. So we give excess lead there. So you can see we pull the sheath out and push it upwards. Okay, rotate it upwards. Now you can see that we can create a loop upwards here. Okay. And then we want to create a big loop so that it's going to be a strain loop so the patient can move, it does not move the electrode. Okay. So we have one upper loop and a lower loop here. Similar fashion at L1. Okay. So you see the lateral view here. This is S2. So we have a 22 gauge SIG needle. We want to find the foramen first before we introduce 14 gauge needle. Okay. So once we find the foramen, there's a 22 gauge. We found the foramen, S2. Now we're going after with the TWI, 14 gauge. Okay. So again, the lateral view. Now we found it's TWI needle is in the S2. Okay. Now once there, we start putting the electrode. Okay. Again, we give a little bit of more slack here because we have to create a loop. Okay? So when we create a loop, the electrode will come back in, just like that. So you can see the loop here. Okay? And then AP view, you can see the loop. Okay? And when we create this kind of loop, we don't even have to use anchor. No anchors for DRG system, okay? Because you don't need it. So this patient, 75% reduction. Okay. Let's change the patient, go over the high frequency stimulation. Okay. HF10 is 10,000 hertz stimulator, okay, made by Nevro. So 10 kV high frequency spinal cord stimulation is also paresthesia free. Okay? It's so frequency so high, our spinal cord does not recognize it. Okay? So you don't get any perception of stimulation. It is a more predictable procedure, okay? Because paresthesia mapping is not required. Okay? It offers the ability to treat challenging back pain and leg pain, and it is also comparable to 3 Tesla MRI. So it is also system is a constant current. Okay? Most of our system nowadays is constant current except Medtronic. Medtronic is constant voltage. Okay? Frequency, this one is 10,000, maximum number electrode 16, and batteries last more than 10 years, even though it's rechargeable. Okay? And the average daily recharging time about 45 minutes. So beauty of a high frequency, as well as a dorsal root gain DRG, is that you don't need to wake up test doing the intra-up. Okay? So traditionally we sedate the patient, we put the lead in, okay, and wake up the patient, and we adjust the location based on the feedback from patient. With the high frequency and DRG, you eliminate step 3 and 4. Therefore, you can get out of operating room very fast. Okay? Why we don't need intra-up testing? Because unlike a traditional tonic system, high frequency, you just have to place it between T8 and T12. So put the 2 lead in, overlap it, just cover the entire T10, T8 to T12. That's it. And then you turn on the stimulation. Why is that? Because the target is not spinal cord here. Target is the dorsal horn. Okay? Neurons in dorsal horn is the target. With high frequency blast, you activate them. Okay? So therefore, where the lead is not important. So look at this. At 3 months and 12 months, control nearly half the people feel the paresthesia. Okay? But high frequency, even after 12 months, they don't feel any paresthesia. Okay? And in terms of efficacy response, back pain and the leg pain, it is much more superior to tonic stimulation. And over 2-year follow-up, that superiority is sustained. Not to be outdone, Boston Scientific comes up with combination therapy. Okay? So they can do both paresthesia free and tonic. Okay? They can automate the waveform. Okay? It's the first system with a combination and has the ability to layer waveform simultaneously and deliver different waveform. Personally, I have not tried this. And the Medtronic comes up with the IntelliJ platform. Okay? The advantage of Medtronic is that they have probably the best battery. Okay? It's smallest. Okay? And another exclusive for Medtronic is adaptive stim technology. Okay? So look at your smartphone. You turn it 90 degrees, guess what happened to your picture? Turn to 90 degrees. Same technology built in this system. Thereby changing the positioning, you don't lose same stimulation. Okay? And StimWave introduced wireless technology. Okay? This is a miniature, very small, and it's very compact. Okay? So you have a small electrode that has everything built in. Okay? It has an antenna, receiver, microprocessor built in. You just need the external antenna to deliver power. Okay? So it has, unlike a regular stimulation, this one you are injecting the electrode just like you're injecting a drug. Okay? So when you just inject, there's no need to anchor it because these spikes open up, it's not going to move. And it can do spinal cord stimulation, DRG, and peripheral nerve stimulation. Okay. And unlike the other system, this DRG is transforaminal approach, external approach. Okay. So it's a little technically challenging. And because it's so small, you can do a lot of peripheral nerve stimulation. Okay. For supraorbital, infraorbital for headache, occipital. Okay. And this patient had a stellar ganglion stimulation. Look at her face. Okay. With improved circulation, her wounds heals better. Okay. And this system is not only low frequency, also can go 10K, high frequency. Okay. So you can do this, because this system is not a small electrode, they cannot do the traditional system that I showed you earlier, the implant technique. So they do transgrade or retrograde. Okay. And because it's so small, you can do knee, okay, right near the collateral ligament, ilioinguinal. Okay. You can put it in the wrist. So okay. You can see very small electrode. You can do angina. Okay. You just put it right on the top of the heart. Okay. And headache, as I mentioned. So this is an injectable system. Minimally, you can just inject into the spine, okay, epidural space. Nuvectra is the one that's stretchable stimulator, and so rationale for spinal cord stimulator is there's a clear need for some patients will benefit from this, especially the refractory pain. And the study does show that some patients will benefit if we put this earlier rather than later. Okay? And we have a high patient satisfaction. And as you know, in the United States, we have an opioid epidemic. Okay? In fact, more people die from an opioid overdose than automobile accident. Okay? So in this study, what they looked at was, here's patients taking opioids, and they introduce stimulator, and opioid reduction occurs. Okay? At bare ranks, I guess I have to stop. But just want to say that clearly, with the stimulator, you can see dose reduction, 28 to 17. Without stimulator, it's going up continuously. So it has an opioid sparing effect. And I think I'm going to stop there. Okay? I'll be happy to take any questions.
Thank you very much, Professor Billy Hu. I think we have all know about the technology. A lot of technology will coming. In Thailand right now, we don't have all of these things that you mentioned. But hopefully, in the future, in very near future, we're going to have those things.
Yes, you got the early preview from me. So in the future, you know when these products come out, you know what yes.
Yeah, and I think maybe our patient will turn to be like a robot that we can control remotely. All right, maybe we can have only one question from the audience, and then we can move to the next session. So if there is no question, so I would like to move to the next topic. The next topic will be presented by Dr. Karina Lee. The topic is regenerative medicine, the fountain of youth. Dr. Karina Lee is a clinical assistant professor in Department of Anesthesiology of the Chinese University of Hong Kong. She is the director of Hong Kong Pain Medicine Center, and she is currently the president of Hong Kong Pain Society and the chairman of Hong Kong Society of Musculoskeletal Pain. So today, she will share with us about the regenerative medicine. Please help me together to welcome Dr. Karina Lee.
Thank you so much for the nice introductions. That's the technology. Yeah, so although now we have more newer technology, but we still have to keep our clinical skill. That's what I'm going to present. Because regeneration medicine, I think, is a new topic and is getting into fountain, it's bosom and fountain. And there's lots of material about. And as you know, I come from Hong Kong, and Hong Kong now is becoming, the oldest people for men and women in the world. So that means that we have a very good support for our elderly in the medical system, and actually it's a huge burden to us. So that's why, although we want our geriatric patients having the good quality of life, but at the same time, we also want to maintain their wellness at the same time with the longevity, so that we don't really, add our burden to our patients. Okay, so. Today, my topic is not only about polotherapy. Initially, they want me just talk about, the injections therapy, but I think we cannot just discussing, the injections without knowing the art of it. So I'm going to have a bit more about the regeneration medicine, from ethics to elderly. So I have a very thank you for very nice introductions. Actually, I see patients from kids to very old elderly, this including age 102 lady with OA hip pain. Can you imagine you cannot see that she's so old? Yeah, and that's Hong Kong. We have a lot of walking elderly, which is above the age of 90 to 100 on the street in Hong Kong. And they can even have a very sound mind. She sings song to me. Very sound mind, and she can take out, a lot of them can take out their Visa card and pay me by themselves with the signature. So, so that's the art. How we can keep them, having a good life and wellness. It's not only talking about, just relieve the pain. It's a kind of combination therapy in a holistic approach. And this is to show you, different sportsmen in Hong Kong. We have a lot of Olympic gold medalists, like windsurfing, Thai boxing, and also this is a different multi-sports athletes. I used to see different adventures, multi-sports athletes. And I would like to show you, this is a Chinese lecture of pain, and we want it to have low pain. So as you see, in the middle, the pain actually is under a cover. This is cover means sickness. And inside the sickness, this means courage. So when our courage is under the shelter of sickness, then we feel pain and suffering. So this is a very beautiful word. And on the other hand, you understand a lot of sportsmen, they have the pain, but they can also perform the sports racing competitions, and they won the medals. Why? Because they have a vision. They have something they really want to do. Although they have the pain, they bear the suffering of pain and even push them further to another peak. So that's my husband. So I would say I have done a lot of regeneration therapy or injections because my husband have climbed up the Everest last May, and he has been racing since the age of 20, and now he's getting into 47. And we try to treat the sportsmen in whatsoever way, such that they can go back to the competitive field, and not only to win, but also to reach their personal best. Especially for the runner, for the triathletes people, they actually not only to win the medal, but they want to achieve their personal achievement. So, you know, that's how our goal for living, isn't it? We live for happiness. We live for doing something we really want to do. And so in order to treat our patients, it's not only we to treat patients just by, but so we all know that pain is a weakening, reflex spasm in musculoskeletal pain. But on the other hand, it's another awakening for the mind and for the soul. It's not enough sleep. And the body and part of the joint are not happy. That's what I always tell my patients. You need to learn how to experience your muscles, your fascia, your joint. Whenever you feel the stiffness, the kicking, you have to know what things go on. And anything about like teaching at the same time, you know, to teach people mobilizations. And so we all know pain is an emotional feeling. And patients, when they want to get their pain cured, or that you have to let them know it's never a cure, you know, for degenerations, for old scar, or for post-surgical wound pain. But they need to know they have the choice. They have the choice to have active coping rather than just the passive therapy. A lot of time, especially for Asians, they rely on passive therapy. I think even for Americans, you know, they have a lot, you know, opioids, analgesics, and, you know, whatsoever different kind of pain interventions. But the thing is that I always say, have you heard of any muscle transplant? Up till now, with modern technology, there's no muscle transplant. Why? Because it's a neuromuscular unit that connects to the spinal cord with the reflex. So what we need to do, apart from, you know, the different ways of manipulations, or, you know, manipulation, many different kinds of therapy, like in Australia, Bowen therapy, and these all work. Even freebies, you know, the freebies Olympic gold medal swimmers, you can see he have a lot of cupping mass while he got his gold medalist last year. But apart from that, it's not actually is something. It's this kind of Asian way is working, but a lot of studies have shown that, you know, it may be short term, it is not long term, and it's not suitable for anyone. You know, it's people are, you know, chasing, you know, after, you know, all the different pain procedures, ultrasound guided polo therapy, which important part. We need to make sense of the root of the pain. Actually, where is? We need the correct diagnosis. Is there underlying pathologies? I have seen a lot of patients being missed for malignancy, metastasis. We have a lot of stage 3, 4 cancer survivors on biologics or, you know, target therapy. And also involving concept of mixed pain concept. You know, the nociceptive versus neuropathic pain, you know. Cervical and lumbar radiculopathy, because they have the dynamic impingement component. And we also have to distinguish arthritis, in rheumatologist conditions with the flare-up of rheumatoid arthritis or stiff or other, Sjogren syndromes, soft tissues inflammations versus some degenerative tendinitis, tendinopathy, calcifications, and the joint and cartilage degenerations. So ultrasound netting us a very good point of care in seeing all these soft tissues to distinguish the relationships between the muscles, fascias, joint, bursa, and then we can using ultrasound as a point of care in the clinic to making a correct diagnosis and also to guide our treatment. In the past, people may do it for nerve block, for steroid injections, or there's some papers saying, the joint needling in different pain conditions. So you have to use the ultrasound to find exactly where is the cause and the root of the pain, and whether the pain is static, systemically with autoimmune disease or gouty arthritis or some other reflex, or the pain is only dynamic, is episodic with movement. So we still need our clinical ultrasound is not everything. We still rely on some simple inflammatory markers like complete blood picture, white cell count, ESR or C-reactive protein guide us. Inflammatory component. Or physicians use ultrasound to diagnose, but sometimes they are too easy to inject prolotherapy or regeneration therapy without really thinking about the underlying cause of the disease, and missing a lot of treatable pathologies like cancer, the most important, and other rheumatoid arthritic conditions. So, if for the myofascial pain, first we have to see, as anesthesiologists, we love to see nerves. That's how I start teaching in Siriwa Hospital back in 2006. We see the nerves evolving, from the nerve root exit zone, and then between the muscles like brachial passes through the interscalene muscles, and then supraclavicular, infraclavicular, axillary. We chase after the nerve, and then at the same time, now with the high frequency ultrasound probe, we can see the fascia. We can see any fasciitis, any thickened fasciitis, any spring and strain, any edema associated with the muscles, any effusions, any increase in the Doppler signal. And then at the same time, we can ask the patient to move. That's the best of ultrasound because we can do it in dynamic. It's not the patient just stay there. When the patient's saying that, whenever I raise up my hand, or they have positive swelling sign, then we see how is the interactions with the scalenus muscles and the supraclavicular level with the brachial plexus nerve, our peripheral nerves, when the patient's moving. So we can see any dynamic entrapment of the peripheral nerves. So this is taken the example of the nerve root. We can see the nerve root exit very nicely. We can see the anterior scalenus muscle, posterior scalenus muscles. So this is a normal. You can see the muscles like normal, okay? You need to learn the normal standard first before you can really chase the nerve down to see any abnormal fascia, abnormal spasm muscles, abnormal scarring or adhesions leading to wobbling of the fascia because all the nerves pass through fascia. So that's how we do our fascia pain block, isn't it? The lumbar passage block and a lot of different nerve block, actually we do it interfascia And we see the target of having a nice regional nerve block is having a nice halo, having a nice rim of local anesthetic spread. So the same, as applying the same principle to chronic pain, we want to see first, before our injections, or really need an injection, is to chase the dynamic movement and interactions between the nerve, the fascia, and the patient's particular movement who trigger off the pain. Just like taking an example of limb pain, then we have different peripheral nerves, and we need to understand the anatomy. Anatomy is very important. Just back to the old days while we're chasing after the nerves, we block regional nerve block. We know the radial nerve hook around the humerus, and while the hook around the mid-humerus is the easiest point of entrapment with the triceps spasm and the triceps movement. So this is something very important, and then we need to learn how to identify the nerves properly, and then we chase after the nerve. While for the lower limb, the common entrapment sites at the lower limb, as discussed in the morning, is piriformis, subgluteal, near the hamstring insertions, we have some subgluteal nerve branching out. And if there's previous hamstring injuries, then it may actually trigger off the pain with the dynamic movement of kicking. And you can see the hamstring muscles, the lateral part of it, and then you see if it is getting full, and it will impinging onto the sciatic nerve before its bifurcations. Some people have early bifurcations into common peroneal or tibial nerve, and some less. And a lot of runners, hackers, or sportsmen, they mostly have the entrapment at the lateral fibular head. And so, as we trace after, we can see if there's any nerve fascia and the soft tissues, dynamic impingement or entrapment with the scarring, rubbing of the fascia. And then we can consider the use of hydrodissection with the fascial split to separate the inflamed or the sticky fascia from the peripheral nerve and prevent the patients having this kind of dynamic movement trigger of pain. So that's neat, to chase the nerve and from the excision down to the point that they complain of the pain and check out for any trigger point or tinal sign. Okay, so what we can see with the ultrasound before we consider for the regeneration therapy or any injections therapy is examinations first, like tendon. Tendon cannot, when we talk about tendon, we cannot not talking how to see muscles, because muscles, fascia, and then at the end of the muscles actually is the tendon. Some tendon, they are oblique, they are one tendon like bicep or tricep. But there's a lot of core muscles, their tendon actually is a fascia, like latissimus dorsi, rhomboides muscles. And so we have to see muscles, whether the muscles have spasm. The muscles have decreased in the circulations. That's we call the trigger points, isn't it? The trigger point is a taban, we have the pain. We still have a lot of studies that we need to do about what exactly is a trigger point. And then a lot of people, start trying to find it with the elastic graph, or the studies is very operator dependent, and is still not very user friendly for clinical use. And in Hong Kong, there's a professor in biomechanics. He's now trying to use cordless ultrasound probe to stick to different muscles, and also the EMG study at the same time to see this kind of dynamic interactions. So that's to show you the brachial passage with different mixed pain syndrome as they pass through different muscles layers. Scalenus muscle, pectoralis muscles. A lot of people having the tablet syndrome nowadays, they have the thoracic inlet impingement. They can impinge at many different areas. And for the back muscles, we see muscles. we can see along the fascial pain to trace whether, the muscles contractions leading to the pain at the end of the attachment to the bone, That gives a lot of ideas what exactly from the myofascial course, or it is a fasciitis with the dynamic movement between the fascias of different muscles. This is another diagram to show you that like interscapular pain, it can be different muscles, suprascapular muscles, or the teres muscles. And this can account for the different pain conditions. And this kind of pain, they may all respond partially to the diagnostic trigger points injections, because the muscles being relaxed and the tensions onto the attachment point of the bone and the tendon also relax. And this allow what? This allow better blood supply to the muscles and better blood supply to the tension of the tendon under stress. So that's come to a point is the discussion. So what is the choice for injections for different kind of myofascial or musculoskeletal pain in the joint? First, we have to use ultrasound to see any real rather inflammatory signals signifying a tear of the muscles, a partial tear of a tendon, supraspinatus tendon, hamstring tendon, or it's just a chronic on acute problem, it's a tendonitis or it's bursitis. So if it is hot lesions, and then we inject, maybe consider steroid, or if it's the severity of the tear. And in some other elderly patients, the pain may be because of fracture. Or therapy cancer patients, the pain is because of fibrosis of the muscles. Then we need to consider injections of Botox, toxin that relax the muscle in the longer term, because just it's not going to work. That, okay, this is a tendinopathy. This is a partial tear. There's a calcifications. And this is osteoarthritis with knee joint infusions or cartilage thinning. So we decide for regeneration therapy, okay? Then we think whether it's a alternative way or getting more evidence that shows injections to induce the inflammations, and then new remodeling, which is the cheapest way. It's very cheap, and it works. There's more evidence showing that different concentrations of that shows is working in different conditions. Platelet-rich plasma, or Asian way of having dry needling, or now a lot of orthopedic surgeons for different like plantar fasciitis, Achilles tendon, they will do tenotomy. Some will open to do it, and some will do it under ultrasound guided. So it's like a Chinese or Oriental way of, we call the needle life manipulations. So this is an old different way of inducing new area, foci of inflammations. And what it can do by decrease the stress shield over a stress tendon. So this decreases the excessive loading that causes the reactive tendinopathy. And this allows increased blood supply to the tendon and allowing the regenerations of a degenerative tendon. So there are many different types of injections. The possible mechanism, for saline injections, it may relax the muscles just by mechanical shielding way, as I said. If it's sticky, peripheral nerve, irritate on nerve, then it helped. But saline also can help induce a little bit inflammations. And there's hypertonic saline and different saline. And there are some review papers or some, scattered cases report. And that shows there are many different concentrations. And there's clearly some direct analgesic effect in epidural or caudal studies. It's hyperbaric and hypotonic, and it relaxes the muscles by mechanical volume effect, and it also induces inflammations and regenerations. And in sports medicine, sometimes they use this to inject into tendon to reinforce the tendon force in subluxations, like in ankle instability. Local anesthetic, yes, it's analgesic effect. It relaxes the muscles. And it also has some anti-inflammatory properties. As we all know lignocaine. Lignocaine is actually decreased peripheral and central sensitizations. It decreases the pain memory in the brain as well. Botox, possible analgesic effect in postherpetic neuralgia cases. It relaxes the muscles. Platelet-rich plasma. It has, induced inflammations, regenerations, and some growth factors and cytokines. It also has some anti-inflammatory properties as well, because people having gouty arthritis, even autoimmune disease, have shown that the use of PRP in rheumatoid patients is also work. Hyaluronic acid, the orthopedic surgeons love to know it. There is high density, low density. There's also some use of hyaluronic acid nowadays, peritendon injections to induce mild inflammations, allow remodeling, and treatment for tendinopathy. It also acts as a lubricant. It's just like a fillers, a lubricant, to help, decrease the rubbing of the fascia and the tissues. And it also serves as anti-inflammatory property. And at the end, steroid. Steroid is anti-inflammations, but it causes fibrosis. In sportsmen, it will cause easy rupture of the tendon. So this is some brief summary for you. And because time is short, and this topic is huge, so I'm not getting into, very detailed reviews because it's a long list. But it's still a lot of controversy. What is the best concentrations for the dashes to be able to achieve the analgesic effect or inflammatory effect or use in osteoarthritis to allow, regenerations? There's some arthroscopic study done by orthopedic surgeons in recent 2-3 years, and I think I'm looking forward to more and more comparison between the dashes and the platelet-rich plasma comparison, and as well as hyaluronic acid. And platelet-rich plasma, is higher concentration of platelet. There are many different sets. There's some 2-compartment system, 3-compartment system, and the aim is 2 to 3 times native concentration in sample plasma. Let's take the autologous blood simultaneously from the patients, and then usually, after I take in the blood, I will scan on the patients, and then during that time to make sure where you are going to inject and pan for it. And then the platelet, how it acts, because as you know, platelet, it will have, leading to aggregations, and it will stick to the damaged tissues or irregular tissues that need remodeling, or damaged cartilage in the joint. So it will activate different thrombocytes and then the other factors. So there's many platelet-derived growth factors, transforming growth factors, vascular growth factor induced, promote angiogenesis, and also we have the collagenase activity. So I'm not going into details because it's a long list. We can discuss more on Wednesday workshops. And these proliferations laying down a lot of materials for the repair. And in sports medicine, is getting different evidence base in improving the knee functions, allowing the sportsman to recover faster or perform better, and it has best outcome in young patients. It's very limited evidence in elderly and geriatric group. Why? Because they don't have the blood supply. Even you inject whatsoever things to the joint, if the joint is under stress of obesity, then it's not going to remodel, it's not going to have any regenerations. So that's something that you need to bear in mind. You know, this kind of prolotherapy regeneration injections is not for everyone. It may be better for sportsmen or young people. They have enough blood supply to the tendon and have the repair ability, but it may not work. So for elderly, exercise of pain and it's also help to decrease. But argument, what we need to tailor make for the patients, and medicine musculoskeletal ultrasound skills, attend more workshops, allowing you what is happening and what is exact pathologies in the tendon, in the ligament, and also, is it because of the biomechanical able to design a treatment for the patients. And it's a lot of things in this sessions, and hopefully you know that with ultrasound we can see many different pathologies, and so we diagnose it before we really talk to the patients what is the best for them. And the things we need collagen, we need and avoid disused syndrome, we need great exercise, remodeling, and then now, healthy bone, avoid a lot of many multifactorial factors. We need to approach the patient in a holistic way. Thank you very much. Is there any questions?
Thank you, definitely. And I think all of us was bombarded by the new information, a lot of information from our two speakers. And okay, so I think we have very limited time. So if you have the question, Dr. Lee and Dr. He will stay with us until the end of the conference. So I think we should have some time for relaxation and refresh ourselves. For the break,
the coffee break will take about 10 minutes, and we will start the last session in on 2:40 p.m. And another reminder for you all participants, don't forget to fulfill your painful room evaluation form. You can download it from the QR code on the screen that they will show you again, or behind your name card. And there will be, at the end of the session, there will be the lucky person will get the free shirt. Thank you.